What should we do when we have a pulp exposure? You have already seen this in a previous video. A direct pulp capping procedure should be necessary only if the operator inadvertently exposes the pulp in attempting an indirect pulp capping procedure. So we have to know how to handle a pulp exposure if it happens. We also looked at why an indirect pulp cap is better than a direct pulp cap. So what are the chances of success of a direct pulp cap? Here are two obstacles to success. Bacterial contamination threatens the pulpal health, and older pulps have less blood flow and are less likely to be able to fight off bacteria. So direct pulp caps are less likely to be successful in older patients. What information do you need to know before treating these teeth? How many can you come up with? I have 4. Here they are. Is the pulp vital? Is there any periapical pathology? Is the patient experiencing any spontaneous pain? And is there any lingering sensitivity? So from that, we get these favorable conditions for pulp capping. Vital pulp. The only way we know that is to test the pulp. No spontaneous pain. We know this by asking the patient. No lingering pain after pulp testing or after hot or cold stimulus. So when we test, we ask the patient and we ask them about symptoms at home. No periapical lesion, so we take a radiograph. And the restoration placed must have a good seal, meaning good closed margins. There are 3 general presentations. In the first presentation, the tooth is vital, the patient has no symptoms or sensitivity, and the patient may not even be aware of a lesion. In the second presentation, the tooth is vital, the patient has some sensitivity but no lingering pain, and the patient has no spontaneous pain. In the third presentation, the tooth is vital, but the patient has spontaneous pain. So which of these has the best prognosis for a direct pulp cap? The answer is number 1, which has the best chance because it hasn't developed symptoms yet. Should we also try a direct pulp cap for number 2? Yes, we should. We just might not have the same success rate that we would have if we had no symptoms. Should we also try a direct pulp cap for presentation number 3? Well, the long-term prognosis is not good if we have spontaneous, prolonged, severe pain. But if we catch the symptoms early, some advocate trying a direct pulp cap instead of endo. Here is a long-term study from Germany. They made their own paste with calcium hydroxide powder and sterile lidocaine, and the clinicians covered the calcium hydroxide with a glass ionomer or ZOP base. After 13 years, the success rate was 76%. That's a really good success rate. Many dentists, including me, would think that's an unrealistically high success rate. Younger patients, under the age of 40, had better results, and again, non-symptomatic teeth had better results. Finally, chances of teeth becoming non-vital was greater in the first 5 years. So if a pulp can make it past the first 5 years, it might be out of the woods. In the next video, we will explore calcium hydroxide and some other options for pulp capping.